The patient presented with left foot drop since 15 days. This is the nerve conduction study.
Dr. Asta, you can see.
Yes, sir. Ma'am, in this, the amplitudes in the right peroneal is normal, 5.6, and also the latency is normal, and conduction velocity is normal, 54. And then in the right tibial also, the amplitude is normal, and latency is normal, and velocity is also normal. But the left peroneal is NR, and left tibial is also ma'am, normal.
Okay.
And the FF studies, ma'am, the latencies are normal in the both tibial nerves.
Okay.
In the sensory one, the right sural, again the amplitude is normal, and latency normal, and velocity is also normal in all the nerves of lower limb except for the left peroneal superficial peroneal, which is NR.
Correct. So what is your opinion of this nerve conduction study?
In this, we can see that the left superficial peroneal as well as in the sensory and in the motor left peroneal, they are two not recordable. So there can be a lesion either at the means basically there can be a lesion either at the common peroneal at the fibular neck or above, either at the plexus or at the roots. That we'll have to rule out. Not at the roots because snap is absent. So it is distal to the roots and proximal to the fibular neck in common peroneal nerve.
Okay. So from this, what will you report this as?
Ma'am, left common peroneal neuropathy.
It's a neuropathy because superficial peroneal nerve snap is absent. Okay. And you have a CMAP which is impaired of the peroneal, left peroneal. Okay. It is absent. So it is an axonopathy, sensory motor axonopathy of left common peroneal nerve.
Yes.
Correct, no?
Yes.
Yeah. So, but localization of the lesion, that left common peroneal neuropathy which has happened, the localization will be given by EMG.
Yes, ma'am.
Correct. So what muscles will you needle now? So according to you, this is a left common peroneal neuropathy. Correct.
Yes.
So now you have to give a localization of this common peroneal neuropathy, whether it is happening at the fibular neck, or it is happening in the mid thigh or just above the popliteal fossa, or yeah, so just above the popliteal fossa. These two things you have to find out. Why just above the popliteal fossa?
Because there's a common peroneal nerve which is involved, so it can be either above the popliteal fossa or at the fibular neck or proximal to means fibular
Yeah,
neck.
so that is a fascicular division of sciatic nerve, na? It is a fascicular division. At the level of just upper border of popliteal fossa, the sciatic nerve divides into common peroneal and tibial nerve. Correct?
Yes, yes.
So common peroneal nerve individually can get affected at two sides. One is at the fibular neck or at the level of upper border of popliteal fossa.
Yes.
Okay, that is a fascicular division of common peroneal nerve. So these two sides are there. So how will you know them? How will you differentiate them? Which side is involved?
Ma'am, the short head of
Which
biceps
muscle will you
femoris.
know? Yeah. Short head of biceps femoris. Yeah.
Yes.
Okay. So this is the EMG.
So, ma'am, in this one, we can see that the left TA is showing spontaneous activity in the form of PSWs and fibrillations. And MUAPs are also showing high amplitude, long duration. Recruitment decrease, interference is incomplete, which is a neuropathic pattern with acute denervation and chronic renervation pattern. And left peroneus longus, I'm also showing positive spontaneous activity and positive sharp waves and fibrillations. And others could not be checked due to poor efforts. And rest, ma'am, left gastrocnemius vastus and gluteus medialis and paraspinal L5, they are all normal.
Correct. So, okay, in this, that needling, the short head of biceps femoris is not there. It was done, it was normal. Okay. So that means the localization goes to?
Ma'am, below the popliteal fossa, that is a fibular neck.
At the level of fibular neck.
Yes.
Correct. So if a patient presents to you with a foot drop, How will you assess that patient? This is just one example. How will you assess that patient? And what all clinical signs will you look for? How do you, like, what are the causes of foot drop, basically?
Ma'am, foot drop can be either at the neuropathy, if you have, then it can be at the common peroneal nerve, that is the deep peroneal branch of that, or the common peroneal nerve, or it could be above that, that is a sciatic nerve, or lumbosacral plexus, or even a L5 radiculopathy. All these are
Okay.
the possible localizations.
Okay, but in the UMN, you don't get foot drop?
Yes, ma'am. Also in the UMN, that is in the ALS or in the anterior frontal infarcts, also we can get a foot drop. That is a
Paracentral, paracentral,
parasagittal. Yes, ma'am.
parasagittal.
Yes.
Okay, so foot drop can be both UMN and LMN. So on examination, what all things will you like to check ki whether it is UMN or LMN? How will you know that from examination this is purely LMN?
Ma'am, firstly, clinical examination, that is if we are getting the UMN size like hyperreflexia, tone increase, all these can help in UMN localization. And fasciculations, presence of fasciculations, decreased tone, areflexia, mute planters, they can help in localizing to LMN, ma'am.
Yes, or drifts. Okay, even drift. If, for example, foot drop comes, then we know upper limb drift. Is there any lower limb drift?
Yes, ma'am. There's a lower limb drift also that we check.
Which is called as? Bars test, na? Bars test. Okay. So you lie on the prone position. No, this bars test is supine position. So you lie on supine position, you lift both the legs from the hip and knee extended. Okay. And then slowly one leg drops down. That is the lower limb. It's like a pronator test, lower limb drift. Okay. So basically, because why I am saying ki many times UMN can come like a foot drop, especially that parasagittal motor area is involved. It can look like just, I mean, even the reflexes and plantar will be zero. So you will not be able to judge. So there are other ways, of course, this reflexes and all will help. And the drift also, lower limb drift also can help. Okay. And also if there are pyramidal pattern weaknesses. So what is the pyramidal pattern of weakness?
There's a involvement of legs of the upper limbs and extensors of the lower limbs.
Yeah. So which muscle will be weak in the lower limb if along with the foot drop?
Ma'am, flexors at the proximally and
So iliopsoas will be weak.
yes,
Okay. Talk in the muscles. So
okay.
iliopsoas will be weak. Then
Ma'am, anterior like dorsiflexors of foot, I
no,
mean
at the
tibialis
hip, what
anterior and
muscles will be weak? One is iliopsoas, and then other is abductor, na?
yes, ma'am.
Adductor becomes strong, so
Glute-
abductor will be weak. That is gluteus
glutei
medius.
medius and
Yeah.
yes,
So in pyramidal pattern weakness, the hip flexion is weak. That is iliopsoas. Hip abductor is weak. That is gluteus medius minimus. Then at the level of knee, the hamstrings will be weak. Quadriceps will be strong. Correct?
yes,
And at the level of ankle, dorsiflexion, plantar dorsiflexion will be weak. Okay. Plantar flexion will be strong. Okay. So whenever you have a foot drop, you first try to find out the pattern of weakness. If a patient has other muscle weakness, then you try to find out pattern, whether it is UMN pattern or LMN pattern. Okay. If it is fitting into this hip flexion weakness, hip abductor and hamstring weakness along with this, so then it will favor your UMN pattern of weakness. Okay.
yes.
So you examine that, then UMN is out, then you start for the LMN. In LMN, anterior horn cells, roots, then plexus, then peripheral nerve, neuromuscular junction, muscle. These are all the localization of foot drop. Okay, all localizations can give rise to foot drop. Okay, so how will you differentiate them? So pure sensory and pure motor, you can differentiate pure sensory or pure motor or sensory motor. Okay, so if it's a sensory motor, then
then nerve, because muscle will be out, ma'am, and NG will be out.
Yes,
And so it
anterior
can
horn
be-
cell will be out.
Yes,
Okay, so roots will be there, or plexus will be there, or nerves will be there.
yes.
Okay, so then from there it is easy to differentiate.
Yes.
So how will you know if the foot drop is because of the L5 root, or if it is because of the lumbosacral plexus, or if it is because of sciatic nerve, or if it is because of the common peroneal nerve? Okay.
Yes, ma'am.
Yeah. So how will you differentiate them?
No, firstly, so clinically we'll see.
Clinically only I'm asking.
Okay. So firstly, ma'am, if it is only a common, that is L5 root, then we'll have weakness in the L5 innervated muscles predominantly. And
Which are
sensory,
those?
like
Suppose if a patient comes to you, he has weakness in the foot dorsiflexion, that is tibialis anterior. There is weakness in the TA. There is weakness in the short head of biceps femoris. Then there is hip abduction weakness. Okay. And then there is hip abduction weakness. So what will you do?
ma'am, it can be either the roots involved, because it is L5, like abductors of the hips, ma'am, involved, glutei,
So it
medius,
could be
and
root or
yes, or plexus, lumbosacral plexus.
yes. How will you differentiate between lumbosacral plexus versus roots?
I mean, the NCS will get completely normal nerve conduction study if only roots are involved. Whereas
Yeah,
in
so the
plexus,
snaps, from snaps you can get to know.
yes,
Correct. Anything
Yes.
else?
then ma'am, ENG panels, we will get
Yes. Yes.
the
Okay.
yes.
So, but the problem is that in the lumbosacral plexus, there can be division. Like somebody has replied that the femoral nerve also, femoral innervated muscles will be. So in lumbosacral plexus, you can get lower lumbosacral plexus and upper lumbosacral plexus. Okay. The upper lumbosacral plexus will give rise to this femoral nerve, obturator nerve, innervated muscle weakness. If it's a lower lumbosacral plexus, you can get just a foot drop, especially alpha S1 innervated muscles. Okay. So if lumbosacral plexus is in giving rise to this foot drop, the only difference between the lumbosacral plexus and L5 is paraspinal muscles. Okay, and of course snaps on the nerve conduction study.
Yes, ma'am.
Yeah. So then how will you differentiate sciatic nerve and common peroneal nerve involvement? Common peroneal nerve at the level of fascicular division. How will you differentiate that?
Ma'am, if it is
Because it is
sciatic,
easier to differentiate if it is at the fibular neck, because the short head of biceps femoris will not will be spared, so it is just the distal weakness. But if somebody has short head of biceps femoris also weak, now what you'll do? Whether it's a fascicular division of common peroneal nerve, or you want to know if it is a sciatic nerve.
ma'am, we'll see the tibial innervated muscles, like the other hamstrings that are there, and gastrocnemius and soleus. If they are also involved, then it indicates sciatic neuropathy, ma'am.
See, so that is the thing. Basically, most important muscle to examine is which muscle? To differentiate between the common peroneal, I mean foot drop because of common peroneal division, fascicular division, or sciatic nerve.
Gluteus,
No.
gastrocnemius.
Gluteus is involved in the sciatic neuropathy.
No, ma'am, in plexus it will be involved.
Yeah.
So gastrocnemius ma'am will be helpful.
Gastroc, more than gastroc, any other muscle? Yes. Tibialis posterior. Okay. That is the
Yes.
most important muscle to differentiate that this is a sciatic neuropathy. Okay. Sciatic neuropathy at above the level of upper border of popliteal fossa. Okay. So
Yes, ma'am.
sciatic neuropathy versus common peroneal neuropathy, fascicular division, one muscle that is the most important muscle is tibialis posterior, which does what? Inversion.
It is a plantar inversion. Yes,
Inversion.
ma'am.
So that is the muscle that you have to check. Inversion. If inversion is also affected, then that means this is a sciatic neuropathy. Okay. If somebody has a foot drop, you examine two actions. One is inversion, and of course, another one is plantar flexion. Okay. If both are
Yes, ma'am.
affected, that means it is a sciatic neuropathy. Okay. And
Yes, ma'am.
this is not a foot drop. Actually, sciatic neuropathy, if pure sciatic neuropathy is involved, then it is not a foot drop. It is a flail foot. Okay. But if common peroneal division of sciatic nerve is involved, then it is foot drop. Understood?
Yes, ma'am.
Okay. So inversion is the most important muscle to differentiate between the sciatic nerve and common peroneal nerve. And the second thing is, if common peroneal nerve is to be differentiated, whether it is involved at the fibular neck or if it is involved more proximally, you have to do the you have to check the short head of biceps femoris. These two things you have to remember. Okay.
Yes,
So
ma'am.
what are the segment pointer muscles in the legs? What are segment pointer muscles? I mean, yeah, segment pointer muscles. In lower limb, what are the segment pointer muscles?
Ma'am, for each root, we have one
Yeah, for
predominantly
each.
muscle inverted by the
It's not
innervated
even
one.
root, it is segments. Okay. So, yeah, so for L1, which is the muscle?
Iliopsoas.
Okay. For L2?
Obturator, obturator innervated adductors.
Okay.
Then, ma'am,
Hmm.
for L3, then ma'am, we have quadriceps.
Hmm.
And also for L4, we use that only. And for
No,
L5,
L4 is not that.
sorry,
L4 is not
L4
that.
is tibialis anterior. And L5 is ma'am extensor hallucis longus.
Yes.
And S1 is gastrosoleus.
Gastrosoleus. Okay. Okay. So, suppose, for example, if a patient has tibialis anterior, so that means that L5 should involve all the muscles, right? Including the tibialis anterior, gastrosoleus, then hamstrings, then it also will cause weakness of the gluteus. That is the thing which will differentiate, na?
Yes, ma'am.
Sciatic nerve from the L5 root. Sciatic nerve from L5 root is involvement of gluteus.
Yes, ma'am.
Gluteus medius and minimus. And from lumbosacral plexus to L5 root, then paraspinals.
Yes, ma'am.
Yeah. And of course, the yeah. So ankle reflex will be absent in
I mean, L5 any radiculopathy also, and lumbosacral plexus also if L5 root is involved.
yes, and also sciatic nerve.
Yes.
In sciatic neuropathy also, ankle reflex will be absent. Okay. It will be spared only in the pure common peroneal neuropathy. Okay.
Yes, ma'am.
Yeah. So we did the EMG in this patient. In 1 minute. So it was a common peroneal neuropathy. So most important table in this is this. Everybody is aware of this table?
Yes, ma'am.
So this will help us differentiate between the T peroneal nerve, common peroneal nerve, sciatic nerve, lumbosacral plexus and L5. L5 involves all the muscles. Tibialis anterior, EHL, peroneus longus, even tibialis posterior. Okay, then short head of biceps also it supplies, and gluteus medius also it supplies. And most important thing that is not supplied by anything is paraspinal muscles. Okay, for lumbosacral plexus, it supplies all muscles except for the paraspinals. And
Yes.
sciatic nerve versus lumbosacral plexus, difference is gluteus medius, or sciatic nerve versus L5, gluteus medius. Okay, clinically I'm saying, because paraspinal muscles you don't get to know clinically. Okay, if gluteus is involved, then definitely it is not sciatic nerve. Either it is lumbosacral plexus, or it is L5 root. Okay, and
Yes,
in the
ma'am.
common peroneal nerve versus sciatic nerve, most important muscle is this tibialis posterior. Okay, and then comes the short head of biceps femoris. But tibialis posterior is clinically very important. If inversion is affected, then it is not common peroneal nerve, it is a sciatic nerve. Okay, and tibialis anterior versus, this deep peroneal nerve versus common peroneal nerve, how will you differentiate?
Peroneus
From
longus.
the peroneus longus, that is eversion. Okay, so in the deep peroneal nerve, EHL and peroneus longus, this thing will be weak, tibialis anterior, but eversion will be spared. Okay.
Yes, ma'am.
Now this patient, he underwent surgery for Whipple's disease, and then he presented with left lower limb weakness and foot drop.
Yeah, Dr. Chandrasekhar, you can try.
Yes.
Yeah, go on.
Yes, sir. Lower limb nerve conduction study. Amplitudes are normal for peroneal nerve at tubular head and popliteal fossa stimulation.
On left
Latencies
side.
on the left side.
Hmm.
On the left side, conduction velocities are also normal for peroneal nerve. TBL on the left side, latency also looks fine, and amplitudes are also fine.
Hmm.
Conduction velocities are also good. On the right side, peroneal nerve stimulation absent responses are noted at both fibular and popliteal stimulation.
Hmm.
Right side tibial amplitudes are okay. Popliteal fossa latency, latencies and amplitudes are normal, ma'am. Conduction velocity also normal.
Hmm.
FAO studies show prolonged latencies, ma'am, both tibial on bilateral, slightly prolonged latencies.
Of what? Of tibial? FAs.
57.
Hmm. For our lab, we have kept it as 62 as a cutoff.
Yes, ma'am. Yes,
Okay.
that's all.
So from, okay, this is a motor, then this is snaps.
A superficial peroneal snap absent on the right side.
Hmm.
Other studies look
Anything else
normal, ma'am.
is abnormal. Okay. So what is your interpretation of this nerve conduction study?
Peroneal, it could be peroneal neuropathy, ma'am, at the fibular head.
That you cannot give the local judgment, that you cannot give the judgment where it
Okay.
is affected from just nerve conduction study.
Yes, ma'am. Looks like peroneal neuropathy.
Yeah, it is a common peroneal neuropathy. Okay.
Yes.
Now,
Yes.
peroneal neuropathy, if it is because of at the level of fibular neck or it's a fascicular division of common peroneal nerve involved at the popliteal fossa. We don't know.
Yes, ma'am. Needle
Okay.
needle. Yes.
Yeah. So we'll have to do the needling. We did the needling. So what does it show?
No spontaneous activity in any muscles. High amplitude, long duration discharges noted in right tibialis anterior with delayed recruitment
Hmm.
and incomplete interference pattern.
Hmm.
Similar findings noted in right shorted of biceps femoris.
Hmm.
Suggestive of involvement of sciatic nerve.
Yes. Why did you say sciatic nerve? Why not fascicular division? Are you understanding what I'm asking?
Yes,
Why you said sciatic nerve and why you didn't say a fascicular division of common peroneal nerve?
ma'am.
Means at the common peroneal nerve division of sciatic nerve getting affected at the level of popliteal fossa. Why it's not that? You understood what I'm trying to say?
Yeah, I got it.
Huh.
Tibialis posterior is
We did not needle only tibialis posterior.
yeah, but gastro
Yes.
as mentioned. Yeah.
Yes. Gastrocnemius is affected.
Yes.
Gastrocnemius needling was abnormal. Okay. So that indicates that
That is
this is
suggestive of sciatic.
more than common peroneal nerve. This is more likely to be a sciatic neuropathy.
Sciatic. Yes.
Okay.
Yes.
Okay. Next. So this is the chart today. I think we discussed this only. So weakness of foot dorsiflexion can happen in common peroneal nerve, sciatic nerve. Then it can get affected in the lumbosacral plexus. It can get affected in the L5 root also. Okay. Deep foot eversion is affected. Deep peroneal nerve doesn't involve the foot eversion. Foot eversion is paired in deep peroneal neuropathy. In rest all, the foot eversion is involved. Then inversion. Inversion is the point which differentiates between the common peroneal nerve versus sciatic nerve. Okay, foot inversion. And another thing that differentiates is, of course, that gastrosoleus. Okay. Then weakness of hamstring. Weakness of hamstring and weakness of glutea indicate what? Weakness of glutea indicate
Plexus or could be radical.
lumbosacral plexus or L5 root. Ankle reflex is absent in
S1 radical.
plexus, root, and even here it is not mentioned, but ankle reflex goes in sciatic nerve also.
Yes.
Okay. And the sensory loss. Yes. This sensory loss. This web space of great toe is for what?
Deep peroneal.
Yes. And then the dorsum of foot is superficial peroneal nerve.
Superficial.
Yeah. Then lateral calf is
Superficial peroneal.
lateral knee.
Lateral knee is L5 or yeah, L5.
L5. Loss, entire sole of foot.
Plantar nose, ma'am. That is sciatic nerve through
Yes,
tibial
sciatic
nerve.
nerve. Sciatic nerve.
Yeah.
And posterior thigh.
Posterior thigh is sciatic nerve
And
S2.
no, it is divided. No, L5 and L4 both are there.
Yeah, posterior is L4.
Okay. So abnormal peroneal snap will be there in the common peroneal nerve, sciatic nerve, lumbosacral plexus. Deep peroneal nerve and L5, the snaps will be spared.
Normal.
Okay, yeah, they will be spared. And sural snap will be definitely impaired in the sciatic nerve. But it can also get affected in the lumbosacral plexus. Okay. And yeah, that is it. Okay. Low peroneal CMAP will be seen in all. Low tibial CMAP will be seen in the sciatic nerve, plexus or L5. And abnormal H reflex will be in all of these three: sciatic nerve, lumbosacral plexus, and L5. Okay.
Yes.
This is the next case.
Dr. Arpita, you can try next.
Yes, sir. Motor nerve conduction study, in which first looking to the right median, latency looks normal, amplitude also normal, velocity 50, yes, normal, that is above wrist, and elbow also, it is normal. Then comparing to left median, for wrist latency, amplitude, and velocity above and below wrist and elbow both look normal. Then right ulnar latency is slightly prolonged, ma'am. At wrist it is no, it is normal. Wrist it is 2.3 normal. Amplitude also normal and velocity also normal. Above and below elbow, amplitude and latencies are normal and velocity is also normal. Comparing to that of left ulnar, also it looks normal. Then coming to lower limb, right peroneal, ankle, fibular head, and popliteal fossa, amplitudes, latencies, and velocity normal. Compared to left peroneal, again they look normal, ma'am. Then for right tibial, latency is normal, amplitude, velocity normal, and for left tibial compared to right side, again they look normal, ma'am. Yes. Coming to sensory conduction, as seen from directly seeing right and left lateral femoral cutaneous nerve of thigh are not excitable. Then right median and left median amplitude and velocity, latency and amplitude velocities look normal. Radial also left and right both are normal. Ulnar also left and right are normal. And lower limb, sural latency left side and right side both are normal, ma'am. Superficial peroneal also normal latencies, amplitudes, and velocity. So as per this, only bilateral lateral femoral cutaneous nerve of thigh is not excitable.
So what is this?
Since it's a direct branch of plexus, it could be lumbar plexus, but only this getting affected in lumbar plexus bilaterally. So L1 could be a possibility, ma'am.
Sorry?
L1, but for L1 root snaps should be normal. It could be femoral
No, so
cutaneous
the
nerves are
lateral
getting
femoral
entrapped.
cutaneous nerve, they are coming, they have the which root value?
L1, ma'am.
No, it is L2, L3.
Yes, I'm sorry. L2, mostly L2 and some part
It
of
is
L3.
L2, L3.
L2,
It is
L3.
L2,
Yes,
L3.
ma'am.
Okay.
Yes, ma'am. So then
Yeah.
it can directly
So, and,
suggest for some
It's
entrapment.
pure sensory. No?
Yes, ma'am. Pure sensory.
We don't,
neuropathy.
here I have not shown the CMAPs, I think, or I have seen. CMAPs are all normal.
Yes,
Okay.
ma'am.
Even the femoral CMAPs is not shown over here. Okay.
Okay, ma'am.
So
Yes,
they
ma'am.
are also normal. It's just a pure sensory
Yeah, then.
involvement. Okay. Bilateral lateral femoral cutaneous neuropathy, which is
Meralgia paresthetica.
yeah. Okay. What are
Yes.
the causes of Meralgia paresthetica?
Obstetric procedures which are taken place in lithotomy position.
And
I'm aware of this one only, ma'am.
those who are like obese people, those who are like have diabetes, underlying diabetes, tight belts,
Okay.
or
Yes,
tight
ma'am.
pants or belts.
Yes,
Even those are the causes. Okay.
okay. Yes.
Okay. Next case.
Next, Dr. Anusha, you can try.
Okay. So
Hello.
yeah, anybody attempting?
Ma'am,
Yeah, Dr. Anusha is attending.
a patient woke up in the middle of the night with tingling in left upper limb and wrist drop.
Yeah.
Yes, ma'am.
What are the possibilities?
So wrist drop could be due to radial nerve involvement
Hmm.
and posterior cord involvement.
Hmm. Any other possibility? You said posterior cord. Why not
Seven.
middle trunk? Why you completely ruled out middle trunk?
Middle trunk C7,
Then you want to say C7 root.
C7 root and middle trunk.
I think UMN is not possible.
Yes, ma'am.
Why
Yes,
stroke? Stroke could be still possible. Na? So suddenly it happened. He woke up in the night with tingling and weakness.
Yeah.
Yeah,
Stroke.
correct. So,
Cortical.
okay. So cortical wrist drop, that is. Huh? So how will you differentiate UMN from LMN then? On examination?
So the present, if it is UMN, finger flexion will also be weak, and there will be hyperreflexia and spasticity. The UMN signs will be there.
Okay. But if they are not there, then many times
So-
you don't see them in the acute settings.
So along
That-
with wrist drop, if finger flexion and wrist flexion is also weak, then it
Many
could be-
times what happens whenever there is a wrist drop, many times what happens that you feel that the introche, matlab patient is not able to carry out the activities of the introche also. Okay, they are not able to adduct the finger, they are not able to abduct the fingers. Okay, and you feel that the other muscles are also affected. But if you examine properly, you may find that other muscles are better than the extensors. Okay, so it is very difficult. Like in the practical situation, it could be very difficult. Like patient comes with a wrist drop, but predominantly extensors are weak, but other muscles also plus minus you are confused whether it is because of the wrist drop itself, the other muscles feel they are weak or they're really weak or not. Any other signs? There are two important signs actually.
pronator drift, madam.
Yeah, so the drift is there. Drift can definitely help. Okay. Then any other?
Supination is weak than pronation, and elbow extensors are weak than flexors.
That is pyramidal pattern of weakness.
Huh.
Then
Cortical sensations.
okay, plantar extensor somebody has written. Okay, that is also acceptable. Is there any sign anybody is aware? Like you ask the patient to outstretch both the hands, both the upper limbs, okay? And you ask them to close the fist. If you do on your own, what happens?
There is flexion of the wrist.
If it is UMN lesion, if it is a cortical wrist drop, or if it is UMN wrist drop, there will be extension of the wrist. Okay, they can close the fist, but there will be extension at the wrist. If you try to do now also, it will be like little bit extension of the wrist happens. Okay, but if it's a LMN wrist drop, the wrist will drop furthermore. Like, understand?
UMN foot drop, there will be extension of wrist on
Foot drop,
wrist.
wrist drop.
Wrist
Wrist drop,
drop,
I'm
sorry.
saying. So UMN wrist drop, if you try to attempt, if you outstretch hand, pronated hand, completely pronated hand, if you outstretch it and you try to close the fist, you can see that the wrist extends. Okay.
Yes, ma'am.
Yeah. So if a patient of UMN wrist drop comes and if you ask them to close the fist, then there will be extension at the wrist joint. Little bit of extension will happen. I'm not saying complete extension. Little bit of extension will happen. But in the cases of LMN, like radial nerve palsy, wrist drop, that happens will be more like there will be more wrist flexion or wrist drops further. Okay.
Okay.
So that is the way to differentiate between the clinically, at least, to differentiate between if it's a cortical wrist drop or if it's a LMN wrist drop. Okay. Then so LMN, there are possibilities of radial nerve versus posterior cord versus C7 root. Okay.
Middle trunk,
Middle trunk also.
C7 root.
Yeah. So this is the next conduction study.
So right median shows normal latencies and no, this is motor, ma'am.
Sorry.
This is
Yeah, this is snap, no?
a snap. Okay. Okay. Right median shows normal latencies and normal snaps and normal conduction velocities. Right ulnar shows normal latencies and normal snaps and normal conduction velocities. Right radial shows normal latencies, normal snaps, and normal conduction velocities. Right median digit 1 from digit 1 is normal, ma'am. And digit 3, 3.1, that is normal latency and normal amplitude. And wrist digit thumb is 2.6 and digit 1 to digit 3, that is 0.5. Okay, lateral antebrachial cutaneous nerve is normal latency and normal amplitude, ma'am. Median antebrachial cutaneous nerve is also normal latency and normal amplitude and normal conduction velocity. Left side median is normal. Left ulnar is also normal. Left radial is also normal. Left median is also normal. Median antebrachial cutaneous now left is also normal, and lateral antebrachial cutaneous nerve is also normal.
So everything looks
So
normal.
So we have, it should be like preganglionic, means it should be root involvement, ma'am.
It
So
could be
see-
root involvement or
cortical.
now possibilities we had kept, yeah, so cortical also. But this is
Cortical.
all snaps only. We have not discussed the CMAPs yet. This is the CMAPs.
Ma'am, I'm able to see only the values. I'm not able to see the, yeah. Right median, CMAPs, normal latency and normal amplitude. Velocity is normal. Right ulnar, below elbow, above elbow, and wrist, normal latency, amplitude, and velocity is normal. Right radial, normal latency and amplitude is less, ma'am, 2.6. And conduction velocity is normal. And left median amplitude, normal latency normal and conduction velocity normal. Left ulnar is also normal. Left radial is not recordable. Right radial amplitude is low. Left radial amplitude is not recordable. And spinal accessory left is normal. Left axillary is normal. Musculocutaneous is normal. Right spinal accessory is normal. Right axillary is normal. Right musculocutaneous is normal.
So what do you think this is?
So this is left.
This is not cortical.
It is in the peripheral now.
Yeah, because if you have a low CMAP or absent CMAP, it is always like, it is LMN. The UMN, the CMAPs and all will be normal. Okay. So this is LMN, but the snaps are preserved. Okay.
So could
So,
should be some means a pure motor innervation like posterior intraosseous nerve.
yeah, very good. Very good. Or
Posterior intraosseous nerve or only the fascicles, motor fascicle should be involved in the radial now. Or
okay.
C7 radiculopathy.
Yeah. So all these three possibilities are there. Is a plexus still possibility? Middle trunk or your posterior cord?
No, ma'am.
Because other things, nothing is involved. No other CMAPs are involved.
No other CMAPs are
Okay,
involved.
no other CMAPs are affected, because if the posterior cord is there, what all muscles should be affected?
So posterior cord gives rise to this upper subscapular, lower subscapular, radial, axillary, and now the serratus anterior.
Yeah.
So should be like
Serratus thoracod dorsum,
Thorac-
no?
yeah, latissimus
Latissimus
dorsi.
dorsi.
Latissimus dorsi. So deltoid should be involved, and
Yeah.
latissimus.
So basically, the first thing is that involved is your proximal radial innervated muscle, that is triceps will be affected. Okay. Then the radial, the axillary innervated muscles like deltoid. Okay. Deltoid will be affected, and latissimus innervated muscle, which are
Latissimus dorsi.
adduction at the shoulder will be affected. Okay, so all these things will get involved in your examination also, and NCS also nothing is there, no? NCS also axillary CMAPs are all okay. Okay,
Yes,
so
ma'am.
this is, and so less likely that this is posterior cord or middle trunk, anything. Okay, so now the possibility that remains is C7 root or PIN palsy. Okay, how will you differentiate between that?
So if it is PIN palsy, this extensor carpi radialis brevis and longus will be spared. When asked the patient to, it will be more of finger drop than that of a wrist drop. When the patient, we ask the patient to extend, there will be radially deviated wrist.
Correct.
pin.
Correct. Perfect.
In
Perfect.
pin
So you
palsy.
do the needling. We did the needling. Now please interpret the needling.
So left extensor indicis proprius, FIPS polyphasics, delayed recruitment and incomplete interference suggestive of neurogenic pattern. Left extensor digitorum communis, FIPS are present and delayed recruitment. So left EIP, extensor digitorum is involved. Left extensor carpi ulnaris is involved. So FIPS polyphasics and delayed recruitment. And left brachioradialis, left triceps, first dorsal interosseous, left pronator teres, they are all normal, ma'am. So three muscles.
Deltoid is also normal.
Deltoid is also normal. So extensor indicis proprius, extensor digitorum communis, and extensor carpi ulnaris is involved. So it is pin posterior interosseous now.
Correct. Correct. So most important thing is snaps is paired. Okay. And the one more thing is that triceps are completely normal. Even brachioradialis is normal. Okay. So ideally you should do the needling of two muscles of each. So that comes to what are the segment pointer muscles in upper limb.
So C5 is deltoid, ma'am. So C6 is brachioradialis. C7 is extensors of the wrist, like extensor indicis or extensor digitorum. C8 is flexor digiti minimi hypothenar. T1 is APB.
No. C8 is what?
C8 means small muscles of the hand, except thenar is more from T1. Remaining small muscles are from C8.
Yeah. APB is T1.
APB thenar is from T1.
APB is T1 and abducted ADM is C8.
C8.
Okay. So these are the segment pointer muscles. So you do the needling of each. If you're suspecting, then you have to do the needling of each root. Okay. So that will also take care of your plexus innervated muscles. Okay. So in this, all the roots are normal except for these extensor indices, EDC and extensor carpi ulnaris. Okay, so this indicates this is a proximal, this posterior interosseous neuropathy. It has paired the brachioradialis and triceps. So how will you differentiate if it is like a radial groove?
So before the radial groove, before entering the spiral groove, then triceps will be involved. After coming to the radial groove, in the spiral groove, triceps is paired and extensor carpi radialis longus and brevis are involved.
Yeah.
And
so these are the wrist drop differentials. PIN, radial nerve, spiral groove, radial nerve in axilla. If radial nerve is involved in the axilla, which muscle will be involved? Additional which
Axilla.
muscle will be involved?
Axilla. Long head of triceps. No.
Yeah, correct. And posterior cord, which muscle?
Posterior cord means
We
all the
discussed,
thigh
no,
muscles.
deltoid will be involved.
Deltoid will be.
Deltoid will be involved. Latissimus dorsi will be involved. Okay. C7 root, it paraspinal muscles. Okay. Yeah. So this is the way to differentiate. Can you read this?
So in posterior introitious neuropathy, wrist drop and finger drop. Okay. So 1 second. Okay, so posterior introitious neuropathy, to differentiate between radial grooves, radial nerve spiral groove, we have to see weakness of supination, weakness of elbow flexion, and diminished brachioradialis reflex, which is absent in pin palsy.
See, it is very easy when you have a patient with a wrist drop. Okay. First thing you ask is the patient to deviate. You ask the patient to close the fist. Okay. So while doing that, that is causing extension at the wrist. There happens a radial deviation. That radial deviation is a pinpointer of the PIN. Okay. Of course, the sensory is also to be considered in that. Then second thing is that at the spinal groove, two muscles. One is supination will be affected. Okay. Supination will be affected and brachioradialis will be affected. Okay. At the spiral groove, supination and brachioradialis will be affected. Okay. And then, PIN is wrist drop. Okay. And deviation on the radial side, it will be indicative of PIN palsy. Supination and brachioradialis affecting will be at the groove. Okay. So that will give rise to weakness of the brachioradialis, and also there will be impaired brachioradialis reflex. Okay. Then you go more proximally. So elbow extension becomes weak. Elbow triceps weak and triceps reflex absent is radial nerve at the axilla. Okay. So difference between the groove and the axilla is triceps. Difference between the groove and the axilla is triceps. Understood? So PIN, radial groove and axilla. The PIN may snaps will be spared. Okay. And this ulnar deviation, radial deviation of the wrist happens. And spiral groove, the involvement of brachioradialis and supination will happen. And at the axilla, triceps will get affected.
Okay.
That's it. Okay. Now, if suppose somebody has triceps also weak and has wrist extension also weak, like wrist drop is also there. Okay. And then the next muscle that you have to examine is deltoid.
Right.
Understood? So when you start needling from the deltoid. You do deltoid, you do triceps, you do brachioradialis, and you do extensor group of muscle, extensor indicis or extensor communis. That is sufficient to do the EMG of a wrist drop. Okay. So if deltoid is involved, that means it goes to
Posterior cord.
either posterior cord or C7, of course, that will remain posterior cord or C7. Okay. Yeah. So if you, and then you check the snaps, and then the snaps is affected or sensory loss in the lateral dorsal hand or lateral posterior arm or forearm, then that is indicative of posterior cord. And weakness in C7, weakness of wrist flexion also happens. And of course, if you needle, then there will be paraspinal involvement also.
Okay. Okay.
So PIN, it is radial deviation of wrist extension and snap spared. Radial nerve at the spiral groove, involvement of supination and brachioradialis. At the axilla, triceps is affected. At the posterior cord, deltoid gets affected. And at C7, you have wrist flexion also weakness and paraspinal involvement. Okay. So that is how you needle also. Okay.
Okay.
Next case.
Next, Dr. Sanket can try. He's not there, Dr. Harshvardhan. You can try.
Okay, sir.
Please read.
Patient present with chronic shoulder pain and inability to lift left upper limbs. Patient is a volleyball player.
So what do you think? What are the possibilities?
Left upper limb. Mostly, sir, ma'am, thoracic outlet and lower trunk involvement, axillary nerve involvement.
Okay. Axillary could be there. Or see, inability to lift left upper limb means not able to do the
Shoulder
overhead
weakness.
abduction also.
Yes. Shoulder abduction also explained. Deltoid axillary nerve involvement, upper trunk also involvement.
Yes, very good. So it could be the axillary nerve, or it could be upper trunk of brachial plexus, or it could be
Pan-plexus.
more nerve. Suprascapular nerve.
Yes, ma'am.
Okay.
Upper trunk.
Could be suprascapular nerve also. Okay. And last possibility of that is rotator cuff injury is there. Okay. So these are the possibility. Most important, suprascapular nerve or axillary nerve or upper trunk of brachial plexus. Okay. So
Yes.
you start examining them clinically. So how will you differentiate?
First, we see the rhomboids and serratus anterior to rule out the root involvement or not. Because a rhomboid is supplied by the C5 roots, serratus anterior C5, C6, C7. If this muscle is preserved.
But serratus anterior, will they complain that they have this shoulder pain and difficulty lifting left upper limb? I mean, overhead abduction.
No, ma'am.
Huh.
Only
Okay,
patient.
you examine the rhomboids. Okay, rhomboids and serratus anterior.
Then we come for the upper trunk muscle involvement, like the supraspinatus and infraspinatus. For the supraspinatus, first 30-degree abduction from the side.
So you examine that. You do the supraspinatus first 30-degree and infraspinatus by?
Adduction of.
Infraspinatus is checked by external rotation, no?
Extension of shoulder.
External rotation at the shoulder. Okay. Then
we come for the trunk, upper trunk. For that we need for the
this supraspinatus and infraspinatus is actually involved in the
upper trunk.
These are the एक minute. See, we have kept the possibility of three things. One is your axillary nerve, another one is your upper trunk, and another one is your suprascapular nerve. Correct, no?
Yes, ma'am.
Yeah. And see, when you start examining the patient, always do the passive movement at the shoulder joint. Okay. So you try to passively do the shoulder abduction. If passive movement is not happening, that means it is local shoulder injury or joint problem. It's a local joint problem. Okay. It could be rotator cuff injury. It could be adhesive capsulitis. It could be anything. Okay.
Yes.
Yeah. So that is one clue that you can differentiate from the shoulder local pathology from the neuromuscular weakness.
Neuromuscular weakness.
Okay. So once you examine the patient that the passive movements are happening and still the patient is complaining of weakness, then it is not arthritis or a shoulder cuff injury. Okay.
Yes,
Then you go for the neuromuscular examination. So you have possibilities of suprascapular nerve, you have possibility of upper trunk, you have possibilities of axillary nerve. So each individual, this nerve which I'm telling, you tell the muscles affected. Suprascapular nerve, which muscles are affected?
Supraspinatus.
And?
infrascapular, infraspinatus.
Bus. So supraspinatus and infraspinatus. These are the
Infraspinatus.
muscles by suprascapular nerve.
Scapular.
Then axillary nerve, which muscles are affected?
Deltoid muscle.
So it doesn't involve, it doesn't it doesn't supply supraspinatus and infraspinatus. Correct, na?
Yes,
So
ma'am.
axillary nerve is just deltoid and
Deltoid and teres minor, ma'am.
yes, very good. Teres minor and deltoid. And what about upper trunk? Which muscle?
Upper trunk, lateral pectoral now. Pectoralis major muscle, lateral lips. Then musculocutaneous now. Ma'am, supply the bicep and bicep brachii for flexion of the elbow.
Hmm.
And the lateral root of median now, C5, C6, is mainly supply the two muscle of forearm.
We are talking
supine-
upper trunk, huh? We are talking upper trunk. We are not talking lateral cord. Of course,
upper trunk
ultimately knows
is,
that only. But muscles I am talking about, muscles which can get affected in upper trunk are deltoid, which you said. Okay.
yes,
Then
Then
you said
number-
biceps.
bicep brachii.
Yes. Huh?
Then supinator, flexor carpi radial is longest.
Yes. Okay. And
Yes.
it affects also brachioradialis.
Yes,
So
ma'am.
deltoid, biceps, brachioradialis,
Flexor
okay.
carpi
Pronator teres,
and pronator
flexor
teres.
carpi radialis. These muscles will get affected in the upper trunk. Okay. So you examine all of that. Okay. From
Okay.
that only you can get to know whether it is suprascapular nerve or axillary nerve or if it is a upper trunk or brachial plexus. Okay. So
Yes,
we
ma'am.
do the examination nerve conduction study. These are the possibilities of this patient. It could be roots also, na? C3, 4,
Yes,
5,
ma'am.
6 also. So this patient snaps are normal. And it showed only supraspinatus and infraspinatus denervation pattern. Then
Then, ma'am, upper trunk involvement is supraspinatus.
no,
Now
I am
to
saying the rest all other muscles are normal, na? It's just supra and infraspinatus.
Then suprascapular now.
Ah, understood.
Yes, ma'am.
All other muscles are normal. Only supra and infraspinatus gets affected. It is suprascapular nerve. Okay. If along with this, if there was in the needling, along with this, if there was involvement of deltoid, then deltoid and supra and infraspinatus, then what would you say?
Then, ma'am, upper trunk involvement.
Yes, very good. Very good. Okay. And if the overhead abduction, you find that only deltoid is weak, then I mean only
Axillary
examination
now.
deltoid, axillary now. Okay. Next case.
Next, Dr. Rishu, you can try.
Ma'am, 20-year-old male, he presented with shoulder blow while playing. He's having left upper limb weakness.
Okay.
Ma'am, nerve conduction study. Median nerve showing normal amplitude, normal velocity. Ulnar nerve, right ulnar nerve showing normal amplitude, normal latency, normal velocity. Right radial, right radial amplitude is reduced slightly, 2.6.
You just check the
Velocity.
left radial also, no?
Yes, ma'am.
So is it
Left
reduced?
radial? Okay, ma'am. Both are equal, 2.6. And median, ma'am, right and left. Left median, ma'am, normal. Latency and amplitude and velocity. Left ulnar is also normal, ma'am. Left, then, ma'am, accessory
left spinal accessory spinal is normal amplitude latency. Left axillary, ma'am, is amplitude is more than less than 50% of right. So left is reduced, ma'am, axillary, and left musculocutaneous and right, ma'am, normal.
Okay,
And
so this is
so,
what
ma'am,
seen.
so ma'am, he is this patient is having, ma'am, involvement of left axillary nerve.
Yes, because if it, why not upper trunk?
Ma'am, in upper trunk, there should be also means in upper trunk biceps will also be involved.
Very good. So musculocutaneous would be abnormal, na?
Yes,
If you do the upper trunk, the biceps will be affected, na?
yes, ma'am.
Biceps CMAP, which is
Yes.
checked by musculocutaneous. So it would be
Musculocutaneous.
impaired. Okay.
Yes, ma'am.
And why not root? C5 root?
Ma'am, in C5 root, then ma'am, in that if root we are talking about, then ma'am, dorsal scapular, then that is also involved in the root. So
Yeah, but we have
rhomboids
not
are
yet
also,
done the needling, na?
yes, ma'am. So that
The
can be a
rhomboid CMAP
possibility.
you can't take. Okay, so that
Yes,
could be a
ma'am.
possibility.
Yes, ma'am.
And why
Rhomboids.
not lateral cord?
Lateral cord, ma'am,
Which
again
muscles are
biceps.
supplied by lateral
Biceps will
cord?
be ma'am, lateral biceps, ma'am, basically biceps brachii will be or musculocutaneous nerve. Then ma'am, deltoid will be supplied.
Correct. So then musculocutaneous CMAP is completely normal.
So that cannot be a possibility lateral cord.
Yeah. Lateral
Yes.
cord ka most important muscle is biceps. Okay.
Biceps. Yes.
So if that is normal, then lateral cord is out. Okay.
Yes, ma'am.
That means this is pure axillary, pure deltoid involvement probably. And that is likely to be a possibility of this thing, axillary nerve or C5 root, we still keep possibility. Okay.
Yes, ma'am. We'll check for rhomboids and so on.
Yeah. Yeah. So denervation in only deltoid and teres minor will be which nerve? It is axillary nerve.
Yes.
Okay.
Yes, ma'am.
If
Yes,
there is biceps, deltoid plus biceps plus supra plus infraspinatus and plus brachioradialis, then it becomes upper trunk.
yes, ma'am.
Agree?
Yes, ma'am.
And along with the deltoid, biceps, supra, infraspinatus, brachioradialis, paraspinals are also affected, then it becomes
Root.
C5, C5.
Root.
Okay.
Yes.
Next case.
Next, what should I, Dr. Harshad? Your exam going, Dr. Harshad?
Yes, ma'am. 30-year-old male playing tennis developed the numbness of lateral forearm and pain and weakness of flexing of elbow.
What do you think, like from exam, from the history, anything, any clue?
From the history, patient is a tennis player and developed the lateral forearm numbness. It may a possibility of lateral cord C5, C6 root median now supply the musculocutaneous now terminated the lateral forearm cutaneous now produces the numbness from the lateral cord. C5, C6 root may be involvement and pain and weakness on flexing of elbow. Also bicep weakness because weakness is also indicate the musculocutaneous now or C5, C6 root or upper trunk.
Okay. So what are your possibilities? Lateral cord?
Lateral cord, upper trunk,
Okay.
or C5, C6 roots.
Okay. This is the EMG. This is the nerve conduction study.
In nerve conduction study, right median amplitude was normal, latency was normal, and conduction velocity is normal. Right ulnar also amplitude, latency and normal. Right radial amplitude 2.6 normal, latency 1.5, and conduction velocity is normal. Left median also normal. Left ulnar 13.2 normal. Left radial also normal. Then accessory spinal is normal. Axillary now on left side is a normal amplitude and latency. Musculocutaneous now is involved on the left side. Amplitude is 2. 50% drop than the other sides, right side.
Correct.
Right side is 4.2.
So this
Yes,
is
ma'am.
musculocutaneous definitely
Correct, ma'am.
affected. Correct, no?
Yes. Yes, ma'am.
You do so what is the possibility then now?
Musculocutaneous now, ma'am, involvement lateral cord.
Correct.
Lateral cord.
Either it is musculocutaneous nerve itself, or there could
Root.
be lateral cord. Correct?
Yes, ma'am.
Then C5, C6 roots.
This is root.
Correct, no? These three possibilities are there.
Yes.
Upper trunk is there possibility now?
No, ma'am. Axillary was normal.
Yeah. Okay, good. So now we do the needling.
Reading left FDA was normal, left APB normal. Only, ma'am, left bicep brachii, spontaneous activity, fasciculation present, and MUP is a high amplitude and long duration. Recruitment delay and interference incomplete. Mostly, ma'am, neuropathic pattern. D and renervation.
So if you say lateral cord, which all muscles should have been abnormal here?
In the lateral cord,
Besides bicep. Besides
Lateral
bicep,
cord
which other muscle would be abnormal?
pronator teres, ma'am.
Lateral cord is LML, na? So lateral root of
Pronator
median
teres.
musculocutaneous nerve and lateral cutaneous nerve of
Ma'am, 3
Hello?
now. Lateral pectoral now. Supply the
lateral
lateral
root
pectoral
of median nerve
now.
and musculocutaneous nerve. So which all muscles would have been abnormal if it was lateral medial cord, lateral cord?
Lateral cord, then left pectoral muscle, then
You can't needle the pectorals then.
pronator teres.
That is very important. Pronator teres. So besides biceps, another muscle that is supplied by lateral cord is pronator teres.
And flexor carpi radial is longer.
Flexor carpi radialis, very good. So there will be wrist flexion. So you can needle these three muscles would have been abnormal. Pronator teres we tried to do. Pronator teres was normal. We also did, I think, flexor carpi usme nahi hai, but flexor carpi radialis was also normal in this patient. So only the biceps was abnormal. So this is most likely musculocutaneous or still like C5, C6 possibility.
Yes.
So can any snap be abnormal in the musculocutaneous nerve?
Lateral cutaneous nerve of forearm, ma'am.
So LABC, na?
LABC.
So if you do the LABC and you find the LABC abnormal, then it goes in more in favor of musculocutaneous nerve than C5, C6.
Yes, ma'am.
Correct, na?
Yes, ma'am.
Okay, sure. Then next case.
Next, Dr. Varun.
Next case, direct case.
Right median compared to left median is bilateral symmetrical. Right ulnar.
This is the right way to read it. Okay, for your sake. In the exam also, try to read like this. You are reading right and left together. Okay, so that becomes easy to interpret also. Okay.
So right ulnar compared with left ulnar. Left ulnar, at wrist it is not recordable, and right ulnar seems normal. Compared with right radial, it is bilateral symmetrical, and Just
Right
some
and left
difference.
radial or normal. Okay.
Normal, sir. Then median also seems normal.
Hmm.
And
Both comparable, right and left median comparable.
comparable, ma'am.
Okay.
Then LABC, ma'am, seems okay only, and MABC also is okay. Fine. Left not recordable, so left MABC is affected, left ulnar is affected. So possibility could be, madam, ulnar neuropathy or medial cord neuropathy. Like
Ulnar neuropathy is there. Okay.
then,
But why ulnar neuropathy? LABC will be normal in affected in ulnar neuropathy.
no, ma'am, like it is.
MABC is the only thing that is spared na in ulnar neuropathy. I
So
mean,
about that, medial medial cord, madam,
or
root.
How can you say root? The snap is absent, so how can we say root?
Then, madam, medial cord only, ma'am.
Lower trunk, why not?
Yes, ma'am, lower trunk, yes, ma'am.
Yeah, so it's a postganglionic problem, na?
Yes,
so
ma'am.
either it is medial cord or it is lower trunk.
Yes, ma'am, yes.
Okay. How will you differentiate between these two? Okay, tell me which are the muscles innervated by medial cord?
Medial cord.
Muscles I'm asking. Muscles innervated by medial cord.
All ulnar innervated muscles and C8T1 muscle medial innervated like APB, flexor pollicis longus.
So all ulnar C8T1 innervated, all ulnar innervated, C8 through C8T1, all median innervated through C8T1, and all radial innervated through C8T1.
Yes, ma'am.
Understand?
Yes, ma'am. Yes, ma'am.
And in the lower trunk, what happens?
Lower trunk, ma'am, like all C8T1 like roots are affected. So entire ulnar nerve MABC will be affected. And
See, medial cord and lower trunk. The only difference between these two is it looks everything same except for the radial innervated C8T1 muscles, which are extensor indicis or extensor digitorum communis.
Yes.
So extensor indicis, especially extensor indicis, that is spared in the lower trunk or the medial cord.
It will be spared in lower trunk.
No, it is involved in lower trunk.
Medial
Spared in medial cord. Okay.
EMG.
Okay.
Yes, ma'am.
So the difference between the medial cord and lower trunk, only difference is extensor indicis.
Okay,
or extensor innervated C8T1 muscles.
Okay, ma'am.
Huh?
Yes, ma'am. Yes, ma'am.
Okay, so from this nerve conduction study, the possibility of lower trunk versus medial cord is there.
Yes.
You do the
EMG.
EMG. You do the EMG. Then what do you find?
Left EIP is also involved, ma'am. Here. Like delayed.
Yeah,
so
first muscle that you checked was EIP. Correct. So left EIP is affected, which means
medial cord, madam.
Left EIP is affected.
So the lower trunk.
Okay. Next case.
Yeah, Dr. Astha, you can try.
Yes, ma'am. Some patient presented with left upper limb pain, had difficulty lifting left upper limb overhead.
What do you think?
So, ma'am, in this clinic, either it could be a upper trunk, or it could be axillary nerve, or it could be supraspinatus as well as trapezius affection. Roots, C5 root, ma'am.
Or suprascapular nerve.
Yes,
Always
ma'am.
think of, keep a possibility of suprascapular nerve. Always keep. Okay. But overhead is not, overhead is a indication of that it is not supra. I mean, supraspinatus is first 15 degrees, correct?
Yes, ma'am.
So this is the nerve conduction study.
I'm in this in the median motor. Here we can see the right side, there is a latency is normal, amplitude also normal, and velocity also normal. And the left side also, ma'am, it is the amplitudes are decreased in the median nerve, that is 1.5, and but the velocity and the latency are normal. And in the ulnar, ma'am, there is in the right side it is normal latency and amplitude as well as velocity. And but in the left ulnar, ma'am, at the wrist, the amplitude is again decreased, that is 1.5, and velocity and latencies are here normal. And then, ma'am, in the axillary motor conduction study at the Erb's point, the amplitudes are normal, and in the accessory spinal, ma'am, also it is normal. And then in the radial, ma'am, again the amplitude on the left side is decreased, that is 1.7. So, ma'am, it means that all the three nerves, radial, median, as well as ulnar, are involved.
This is motor. Huh? Now we'll go to snap.
I mean, the lower limbs, the peroneal and the tibial, they appear to be normal.
Correct.
And the one median sensory, here we can see again is latency, amplitude as well as velocities are normal, and ulnar also, ma'am, the latency is normal, and amplitude is 12 normal, ma'am, and velocity also normal. Radial, ma'am, there is a
No, what you are saying, the median snap, you tell median snap is normal, no? Right, left, RL is right and left. Huh? So
okay.
median snap, RL is right and left. So that is normal, median snap. Similar, acha, you read it like that. So here also you see the median right, left. So left ka median is of low amplitude here.
Yes, ma'am.
Okay. And ulnar also, left ka ulnar is low amplitude over here. Okay.
Yes,
and
ma'am.
radial also, left radial is low amplitude over here. Okay.
Yes, ma'am.
But all like proximal CMAPs are all okay. Axillary and spinal accessory. Okay.
Yes.
Then you do the median. I mean the snaps. Those snaps, median snap is okay. But ulnar snap here left is absent.
It's 0. Yes, ma'am. Left ulnar snap is 0.
Absent. And left radial snap, you see?
Reduced, ma'am.
Yeah, it is reduced. What about LABC? Left.
And that is not recordable. Left.
Correct. So what is your interpretation from this now?
So, ma'am, as in the motor part, all the three nerves are involved. And in the sensory also, we can see that there's left ulnar radial as well as left LABC. As LABC, ma'am, is a branch of musculocutaneous nerve. So it is a lateral cord as well as other nerves. So it means that it's either a pan-brachial plexopathy.
Hello?
Yes, ma'am. So it could be a pan-plexus involvement where all the three nerves, motor, median, ulnar as well as radial are involved, and also the lateral antebrachial cutaneous, suggestive of musculocutaneous involvement.
Okay. But do you want to say this is pan-plexus, or it could be some one plexus fitting into one plexus? Why it's not fitting in one plexus?
Ma'am, because if LABC is involved, one possibility in all the three nerves involved is lower trunk also, ma'am. But here as LABC is involved, so that is a branch of lateral cord. So therefore lower trunk is not supplying that. So therefore lower trunk possibility is not there.
Correct. So LABC is involved, ulnar is also involved, radial snap is also low. Okay, so that is indicative of possibility of pan-plexus involvement. This is nothing. You do the needling. This is the needling.
Yes, ma'am. So here also we can see that C8, T1 innervated muscles of the hand, they are involved. Left EIP also involved, ma'am, and but brachioradialis is normal, but biceps, deltoid, triceps, FCR, they are involved, and rhomboids also, but paraspinal and supraspinatus, ma'am, they are normal.
Yes.
So it means that it is not a root lesion, and beyond that.
Yes. Rhomboids is showing innervation, denervation. Left rhomboids. Supraspinatus is paired, but rhomboids is showing denervation. So why is it showing denervation? You are saying that it is pan-plexus, then why rhomboids is showing denervation?
It means, ma'am,
Rhomboids
root
is
is
pure
also
root,
involved.
no?
Yes, ma'am, it is C5 root. It is the root branch. So it is also showing changes. So then it is a possibility of root involvement now.
But the snaps are affected.
Ma'am, it could be avulsion sort of injury where roots
Very
have been
good, very good. So it is both preganglionic plus when you're reporting this, we'll have to report this as this is both pre plus post ganglionic. What do you say? Pre plus post ganglionic axonopathy, sensory motor axonopathy,
Yes.
involving both all the plexus plus roots.
Yes, ma'am.
Correct?
Yes, ma'am.
This is roots or spinal roots or a plexus root? Is there a difference between them?
Yes, ma'am.
So these roots we are talking about plexus roots.
Yes, ma'am.
And rhomboids is coming from the spinal root.
Yes, ma'am.
Okay. So yeah, so this is a pan-plexus plus roots also additionally involved.
Yes, ma'am.
But in the pan-plexus also, which plexus is more affected in this?
I'm predominantly lower trunk because C8, T1 innervated muscles are mostly involved, and there's slight sparing of supraspinatus and LABC. So
Yeah.
therefore, upper
but
trunk and
what LABC was affected. LABC was affected.
Sorry, LABC also affected. Yes, ma'am. I mean the supraspinatus is spared and cervical paraspinals and also brachioradialis is spared. So C6, 7 innervated muscles are comparatively spared, and C1 are predominantly involved. All of them are involved.
Deltoid biceps is involved. Okay. Deltoid is not
Yes, ma'am.
normal. There is
They
a
are
chronic
also involved.
denervation in the deltoid also. So it's a pan-plexus only. Okay.
Yes, ma'am.
Plus roots involvement.
Yes.
Okay. 1 minute. So this is the difference like upper trunk, middle trunk and lower trunk. Upper trunk is formed by C5, C6, middle trunk C7 and lower trunk C8, T1. The pure muscles which are involved in upper trunk plexus is deltoid, biceps, brachioradialis, supra and infraspinatus. These are the major muscles of upper trunk. And the sensory loss will be lateral arm, forearm. That means LABC will also be affected of hand and thumb. Okay. And biceps and brachioradialis will be impaired, and triceps will be normal. Middle trunk is C7. Muscles involved are triceps and flexor carpi radialis and pronator teres. Okay. And sensory loss is over the middle finger and posterior forearm. And triceps reflex is depressed in the middle trunk. And lower trunk, ideally you don't get individual middle trunk. It's very rare to get a say, individual middle trunk plexopathy. Lower trunk plexus, C8, T1, all ulnar innervated muscles plus APB, FDP, and extensor indicis and extensor pollicis brevis. So all these muscles are affected, but remember extensor indicis, that differentiates it from the medial cord. Okay, and lower trunk, medial arm, forearm, that is MABC is affected, and ulnar nerve is also impaired. Okay, in this. No reflex abnormalities in lower trunk of plexus. Lateral cord plexus, plexopathy, posterior cord and medial cord. So lateral cord, that is lateral pectoral nerve, lateral root of median nerve, and musculocutaneous nerve. So musculocutaneous nerve is going to supply biceps brachii, coracobrachialis, and brachialis muscle. So, and also it gives off LABC. Okay,
Yes,
and along with that, a C6, C7 part of median nerve. That is lateral cord plexopathy. So muscles in the lateral cord are main muscles are elbow flexion, which is biceps, and pronation, pronator teres, and
Yes,
also wrist flexion, also flexor carpi radialis. So sensory loss will be LABC, lateral forearm, hand, and first 3 fingers. That is median nerve. Okay. So DTR, biceps will be abnormal, brachioradialis and triceps will be spared in lateral cord. Okay.
yes.
Then posterior cord, radial, we know that it is thoracodorsal, which is latissimus dorsi, axillary nerve, that is deltoid, and this thing, radial nerve, which is triceps and wrist extensors. So there will be wrist drop, there will be finger drop, and there will be triceps weakness also in posterior cord. And the sensory loss will be lateral arm, posterior forearm, okay, and dorsal hand. And triceps will be impaired. Triceps and brachioradialis will be impaired. Medial cord, it is identical to lower cord except for extensor indices. That's it. Okay.
Yes.
Main difficulty is always differentiating between this posterior cord, radial nerve palsy, and this lateral cord and upper trunk. Okay. Yeah. I think, sir,
Yes.
today's cases are over.
Yeah, any other cases are pending, madam?
No, actually, I was thinking that RNS and all I'll take with the next session. That
Yeah.
RNS, then single nerve fiber together, I'll take in the next session.
Okay. One question is asked by Dr. Darshan. Rhomboid is supplied by dorsal scapular nerve, or which is the branch of upper trunk or root?
Root. It is coming from root.
Yeah. Anybody have any other question?
No question. Everybody has understood.
Tomorrow, Dr. Praveen sir is taking ENMG class. That also will be continuation of this presentation. And thank you everyone for answering Dr. Swaleha madam question and participating. And next Wednesday and Friday, madam will continue the remaining neurophysiology.
Yes, sir.
Thank you, madam.
Okay, thank you.
You
Thank
can
you,
close
ma'am.
the session.
Okay.
Yeah.
Thank you, madam.
Thank you, ma'am.